articles done on the topic. I don't know if that's what this study was that Dr. Is it Zilke? Z-I-L-K?
Vilke, V-I-L-K-E.
Vilke, okay.
So
Mm-hmm.
I mean, I think this harkens back to the discussion that we were having the other day, which is this impeachment, or are they getting it in for the substantive matter of what Dr. Vilke is stating here? I mean, it's all hearsay. We can agree upon that.
Well,
And our doctor has never seen this video, never relied upon it. It would be completely improper. I don't see under the rules of evidence how it would be admissible to be played to the jury.
it's, so explain it to me, Mr. Lowe.
Well, whether she's seen this video or not, he is the authority that she is citing for her opinion that weight on the back. I'm anticipating that she's going to testify that weight on the back does not impact reading, and relying on Dr. Vilke's prior studies. However, he is now saying that weight on a person's back can limit the ability of someone to ventilate, and this is what the video shows. And so it's impeachment.
She's never seen it. She's never reviewed this. I mean, this is exactly what Hamilton talked about and what the Court of Appeals overturned a third strike conviction on because they were getting...
Hold on a second. It's not a learned treatise, right?
It isn't, but it is from the author of a study that she is relying on. So it's impeachment, regardless whether she's seen it or not. I mean, we can show it to her before she testifies, but this is something that's she's relying on, an author that
Well, she's not relying on this.
No, but she's relying on this person's study.
Well, if there was something in the study that was inconsistent with what she's saying, I could understand that. How is it an exception to the hearsay rule? Never mind Mr. Conrad's drumbeat of impeachment or of confrontation.
Well, it's expert testimony and data that she's relying on to support, and data that's hearsay to support her testimony. And we certainly, on cross-examination and impeachment, can bring in that same type of evidence from the same author of the study she's relying on to show that his position has changed and how that impacts her opinion, whether it impacts her opinion or not.
Can I hear this again?
Any position that creates the impact of potentially limiting oxygenation is what positional asphyxia is. A certain amount of weight put on a person can limit their ventilations and create that oxygen-deprived state. Once you get them restrained, I think the expectation is you are now responsible for them as a almost surrogate medical provider until one gets there. If all of a sudden he's no longer resisting, do what you need to do, but then really try to do a rapid medical assessment because there's likely a change in status that happened in that case. They are breathing heavy and then they stop breathing heavy and you're not sure if they're breathing. That's concerning. If you're not sure whether there's a pulse, you're not sure if they're breathing, that's the person that probably does need CPR.
Well, that's a little different from what I saw before, right?
It's the same thing.
Is it exactly the same thing? Okay. it was mostly the same thing, I thought. Well, anyway, see how you pick up something different each time. But he's talking there about when you should do CPR, right?
He does.
Caretaking. I don't think he's even talking about position. I don't even know if he's talking about position asphyxia.
Your Honor, that's fine. I mean, I think it's the first portion of his testimony that's significant with regard to weight on someone's back.
See what he just says, his testimony.
Or not his testimony.
Well, it looks like it was testimony in some kind of proceeding.
Well, it's testimony, because that's what they want him to do here, is testify without him present.
All right. Enough of the style points. Let's get to the substance of this.
You're right.
From this little clip, I don't know what the doctor's view is on all this. And I don't know if he's disavowing his study or not. It could be that he's got one point of view and his study suggests a different point of view. It's already been discussed that there are different opinions about this.
But this is the author of a study that Dr. Stankus primarily relies upon for her testimony from position asphyxia, which is indicated in the report and has interviews with us. And this author now is now saying that weight on a person's back can limit the ability of a person to ventilate and create oxygen deprivation. And so this is different from what was indicated before. And so I want to be able to impeach Ms. Dr. Stankus with that new viewpoint.
Well, one of the things that's been, I guess, elusive here, it's been mentioned in some context, but in terms of how much weight, how long a period of time, and so on. Maybe this is all completely idiosyncratic, but it doesn't sound like anybody has suggested how much time and how much weight would make a difference. He did talk about at the end here, under certain circumstances, you should start CPR if you can't get a pulse and so on. Of course, we know that Mr. Ellis had a pulse at the time medical aid arrived. I don't know. The idea generally that there's a limitation on somebody's ability to ventilate, I've always thought, frankly, and I think I've said this earlier, I knew that from my brother sitting on me as a child. It does make it harder. How long that would have gone on, whether he would have killed me or not, I don't know. I'm sure there are moments where he wanted to. Anyway, Mr. Oster, you've risen. I assume you want to say something.
Judge, without the question and the context, we have no idea what he's actually referring to. He could be explaining the opposite viewpoint. For those that do think this, explain it. Well, there could be saying additional weight can cause the restriction. And then it's edited to, well, if somebody's in restraints, we don't even know the context. I think it's disingenuous, and without the proper foundation, under 403 should not be admitted at all, or used at all.
If counsel wants a whole video, we certainly can provide the whole video so they can see the context.
I don't know. Maybe they do. I don't know. But that is another point about this. We don't know the context, and you couldn't have introduced this as standalone evidence
No,
in this case, right?
This was impeachment. This is, again,
But
the author of the study that
maybe if he said something like, I know I wrote this article that says this and what have you, but you know what? Upon further reflection and additional analysis, I realized that was erroneous. If he said something like that, maybe I'd let you go there. I don't know what this is all about. So I don't see it as proper impeachment either. Unless she somehow knew about this and considered it and discarded it, and then she can explain all that. But if it's not part of her analysis,
well, it is part of her analysis that the author of the study that she's relying on.
well, yeah, but I don't know that this is referring to the study. And as I said before, it could well be that the study that he did was a metadata analysis, which, as I say, I've seen studies like this where they're reporting on what what the studies are saying about this. So you're taking 300 studies of a similar kind of an issue, and this is what the opinions are, and then they're reporting all that so that professionals in the field can have some idea, one, of what the breadth of the opinions are, what seems to be true and what doesn't seem to be true after looking at all this, and maybe where the consensus is going. And he may or may not necessarily agree with some aspects of the meta-study that they published, but they could still publish it saying this represents the view of a segment of our profession. I mean, I just don't know anything about the study she's relying on. I don't know anything about this document. As I say, we agree that as a standalone proposition to be presented to the jury would not be admissible. So then the only question is it actually admissible against her? And I suppose you could certainly ask her whether or not there are other, just as was asked by the defense, whether or not there are other people who feel differently in the field. She might acknowledge that. But I don't know whether this really represents a change in Dr. Vilke's position. I suppose you might ask her if she knows anything about Dr. Vilke's position. If she says current position, if she says she doesn't, I'm not sure you can necessarily get this in. If she says she does, you might ask her what it is, and she might tell you this very same thing. I don't know. But then also tell us why he's wrong.
But even if she does indicate she's never seen it, I think we're entitled to show her, play the video for her to see. It's no different than presenting an article to an expert, asking whether that expert.
Well, that's why I made the reference to the learned treatise exception, and at least when you're talking about somebody on direct examination, you do have to sort of establish whether it's considered authoritative in that field. Although in cross-examination, the rules about that are usually somewhat relaxed. I'm just going here. I've turned the page here to it, and I'm looking at, this is on, and I'm looking at now Teglin's, I think we got a new version of this now, but I don't have it in front of me. This is Teglin's 2022-2023 edition at page 473. But this is not a learned treatise, because for one thing, it's not.
Peer-reviewed, it also has to be relied upon by the expert.
Well, but see, as Teklin points out, as I was just mentioning too, quote, the discussion in the preceding section assumes the use of a treatise on direct examination, typically to explain or support the witness's own opinion. When the use of the treatise is limited to cross-examination, the foundation requirements are less rigorous. The rule requires only that the treatise be called to the attention of the witness being cross-examined. The cross-examiner need not establish that the witness has relied upon the publication, or that the witness regards it as authoritative. If the rule were otherwise, the witness could frustrate cross-examination by refusing to acknowledge the treatise. So that's why I went to that in terms of an analogy to Mr. Liu's situation here. But we don't necessarily have the fullness of what this all is. It isn't a publication that we're looking at here. It looks like a deposition transcript or excerpt. I don't know what it was exactly, but it looks like they were in some kind of facility, What was it? A deposition? What was it?
No, it wasn't a deposition. I believe it was a training video.
A training video for what? Law enforcement?
Yes, correct. For what?
For law enforcement. Okay.
So, Your Honor, I would suggest that we allowed an opportunity to play the video for Dr. Stankus outside the president's report. That way
Well,
she-
you did take her deposition, right?
Right, but this video only came out after her interview.
Judge, we don't even get to learned treatise. This is not a learned treatise.
No, it's not.
So I don't understand why.
Because I'm reaching to the best possible analogy to discern whether or not this is merit worthy, and it isn't meritorious as I can tell. As I say, you want to ask Dr. Stankus about her knowledge of the doctor's views on this. I suppose you can maybe somehow get there. Maybe she's aware of this. Maybe she's not. Maybe it doesn't make any difference. The context of this does matter, and I don't know what that is. I mean, as I said before about my brother sitting on me, I mean, it certainly would be best if you could avoid that. I would think, no matter what. And the training here that we've had discussed was to that effect. I mean, everybody says, well, we wanted to put him in the recovery position. Why? What would the point of that be if it wasn't something to do with we're worried about his capacity to breathe, right? I mean, but my point earlier about we don't know how long, we don't know how much weight would cause any kind of an issue is not answered by this video and by nobody that's testified so far. Even those who have testified about this say, well, you can't opine about that because I don't know. Your pulmonologist, I think, said that. Maybe your cardiologist said that too. I don't know how much weight there was. I don't know how long it was. I don't know what the exact positions are. But what I wondered about as they were saying that is, if you did have all that information, could you still formulate an opinion? Is there actually any science about this? I'm guessing there isn't. Except that it's probably a good idea not to do this.
Right, that's the point of the author. We're not going to actually put people under that type of condition, so
Right.
we'll never know. But
Right. Dr. Stankus might agree. In general, you should avoid this if you can. I mean, I don't know. I don't know what she's going to say.
and we're not going to go into this course through this video. We just want to explore whether Dr. Stankus is aware that the author of the study that she's primarily relying on has changed his opinion regarding weight.
Okay. Well, from what I've seen, and given that it's apparently its issue has to do with training law enforcement, which is a kind of use and force kind of question, I don't see that, and it's not a learned treatise, and it isn't admissible all by itself. I don't see how you can use it. So that's my ruling.
And is, of course, ruling that the state cannot cross-examine Dr. Stankus on this particular video?
Not with, yeah, that's right. At this point, that's
Or
right.
knowledge?
You can't play it for her,
Understood.
okay?
I understand, of course.
So then what else, so what are you talking about? I said, are you interested, does Dr. Vilke have, does Dr. Vilke's views, current views known to you? Have they changed? You know, maybe ask her that. Do you know if he still stands by this? She may or may not have an opinion about that, but even if she says, I don't know that you can get to this.
Understood, Your Honor.
Because I'm not sure this actually represents his view about his study. He still might say something like, the study stands, but it's not a good idea.
Yeah, there's two issues. One is police training, and the other is, does it cause any medical significant issue that would cause hypoxia? And that's the medical question.
Well, yeah, but you know, it's been kind of loosely said, but the police training as to this has to do with some kind of belief about the medical consequences of it. It's not in a vacuum. I mean, you know, if it really had no difference whatsoever, why would they even care? You know, unless the reason was something like, this aggravates your suspect and makes the whole the rest of your interchange with the suspect more difficult than it needs to be. I mean, that's the only other thing I can think of that would make sense for this, but I'm kind of reaching to get to that. No, to me, it has to do with some concern that there's a potential medical consequence for this. I don't think the state's crazy about that, but I don't know that this is admissible. So, let's have the jury and the witness. Okay. Mr. Conrad, who is your next witness?
I'm to call Dr. Jennifer Stankus.
Yes, please come forward to right about here and raise your right hand to be sworn. Solemnly swear or affirm that your testimony in this cause will be the truth, the whole truth, and nothing but the truth. Thank you very much, ma'am. Please have a seat right here. Please state your name and please spell your name.
My name is Jennifer Stankus, Jennifer Stankus.
Thank you. Mr. Conrad.
Good morning, doctor.
Good morning. Whoops.
I want to start off and the jury gets to know you and your background a little bit. Can you tell us what your primary occupation is?
I'm an emergency physician.
Okay. And how long have you been practicing as an emergency room physician?
Since 2009 when I graduated from medical school.
And what's your educational background?
So I started at Chaminade University in Honolulu, ended up finishing at the University of Colorado at Boulder with a degree in psychology. I then went to law school at the University of Denver, and then ultimately went to medical school at the University of Washington.
Okay. And can can you tell us about kind of the different jobs that you've had as well leading up to, it sounds like emergency physician has not been your only job.
No, I graduated a couple of years early from high school, and at age 17 joined the Naval Reserve. I enlisted. I did that for about 8 years as a medic, and a little bit of that time as a military police. I worked my way through college, and during that time, for maybe 2.5 years of that, I worked as a police officer. I've done mountain rescue, a bunch of things before medical school. And then, of course, after law school, I worked as a JAG officer in the Army. I was a hospital attorney and a part-time military magistrate.
So why did you go to medical school?
You know, I had a love for medicine from the time I was also a volunteer ambulance attendant, or EMT, in Colorado, and my dad was a physician. He kept trying to persuade me not to go that route, but I just kept coming back to it. I really enjoyed medicine, especially emergency medicine. And after my time working in the hospital as an attorney, my passion for medicine just grew from that. And so after I got out of the military and we moved back to Washington, I decided to apply to the University of Washington. There was a period of time between getting out of the military and that I did some trial support with the U.S. Attorney's Office in Tacoma, but then was able to get into medical school and pursue that dream.
So what you said that there was something that drew you about emergency medicine. What was it that drew you towards that?
So, like I said, I had worked on an ambulance. I'd done medic work. I'd done volunteer ski patrol. I just always had a passion for that, and I really enjoyed working with all of the EMS people, and it was just kind of my niche, I guess. And I really enjoy the fast pace of it and having to figure out things quickly on the fly. It's just, it's kind of an exciting job.
And are you board certified?
I am.
What does that mean, to be board certified?
So in order to be board certified, first you have to go through residency training. Graduate from medical school first, then residency training. And if you pass that, then you are allowed to sit for a written test. If you pass that, then you go and have an oral board examination. And if you pass that, then you become board certified, and then you have to maintain that.
And what are you board certified in?
Emergency medicine.
Okay. And are you a member of any professional society?
I am the American College of Emergency Physicians.
Do you hold any status with them?
Status, sure, I'm a peer.
Like leadership positions?
Sure.
Like that?
So I have been a peer reviewer for their journal called Annals of Emergency Medicine, which is the Tier 1 journal in emergency medicine. I've been doing that for a decade, I think. I've been on the editorial board for their kind of monthly magazine, was on the board of directors for the Washington College. It's kind of embarrassing, I was a little bit gung-ho, and so the day I got my acceptance to medical school, I joined ASAP and applied for a committee and was on a medical legal committee, which I chaired for several years, for 11 years, and then multiple other committees and task forces and things like that. So I was very active for about 12 years with ASAP.
And what hospital are you currently working
Madigan Army Medical Center.
at? Okay. And how long have you been working there?
Since 2015, I started taking shifts there in 2015, and then that's actually been my dream job. And in 2016, a full-time position opened, and I have been there ever since.
And when's the last time you worked a shift?
Monday night.
Okay. And what hospitals have you worked at prior to Madigan?
Prior to that, out of residency, I started primarily at St. Joe's. I worked there for about a year. At the time, Kaiser was trying to convert some of they were hiring emergency physicians to try to convert some of their freestanding or urgent cares into more like freestanding emergency departments. I did that for a couple of years. I didn't feel like it was it's kind of I was used to working in a level 2 trauma center, and it definitely wasn't that. So I went and worked at Tacoma Emergency Care Physicians at Tacoma General for a little less than another year, because the position at Madigan opened up, and I've been there since.
And this St. Joe's Hospital, is that here in Tacoma as well?
Yes.
Okay. And do you teach?
I do. I have been on national faculty for the American College of Emergency Physicians. I was a what they called a residency ambassador, where I'd go around to some different residencies and give a talk. I have taught for a company called Vapotherm, which during COVID, that became a really big issue, where they use these high flow nasal cannulas for undifferentiated respiratory failure, or we used it a lot in COVID. And then I teach every time I work a shift, because we train emergency physicians who are active duty military out at Madigan.
Okay. So I want to talk about some of like what it means to be an emergency physician and what type of patients you treat. So let's start with that question. Like, what is it to be an emergency physician?
So I jokingly say, but it's true, that we take everything that gets dropped off, brought in, or walks in through the back door, which is true. So we take care of any type of traumatic injuries, any type of medical emergencies, and kind of everything in between.
And you talked a little bit about what type of patients, but can you give us an idea about Madigan, what type of patients you've been seeing?
Yeah, so at Madigan, at least during the day, it's like a big city. So we would take care of any medical or traumatic emergencies that happen on post, in training accidents, or with people who are working there. We also take care of all active duty soldiers, their dependents, and a lot of retirees. And then we also take care of people in the surrounding community if we're the closest facility. So as an example, when we had that train derailment, that the train went off the tracks and onto I-5, all of those patients came to us. We'll see people who are brought in with knife and gunshot wounds, or having a medical emergency because we're closest.
Okay. And so you've also worked as a first responder, is that right?
I have.
And so how many times throughout your career, and this may be difficult to explain, but how many times do you think that you performed CPR?
Hundreds. I don't know.
Okay. And how many times have you treated patients that passed away?
Dozens.
And how often do you treat patients with cardiac issues?
I'd say pretty much daily.
Okay. And what about respiratory?
Again, it's a very frequent complaint.
What about addiction issues?
Very frequent. Especially at Tacoma General and St. Joe's. Not as much at Madigan, but certainly at, believe it or not, even with our soldiers.
And do you take care of cardiopulmonary arrest?
Yes.
And so what is it? Well, let me ask you this. Do you often look at EKGs in the emergency room?
Probably 40 a day.
And what is an EKG?
It's a tracing of the electrical activity of the heart. I guess that's the simplest way to put it.
Okay. And do you have experience in determining whether the patients that you see in the emergency room are having a cardiac issue versus a respiratory issue?
Yeah, so one of the things that sort of defines our specialty, I would say, is that people will come in distress, and we have to fairly quickly figure out what's going on with them, because how you would treat one may be very different from how you would treat another.
Okay. And how often do you make that assessment?
Very frequently.
How do you make that assessment?
So Lots of ways. Our physical exam, interacting with the patient, getting history, putting the person on a heart monitor so we can see what the heart is doing, putting the person on a pulse oximeter so we can see, what is the oxygenation in their blood, putting the person on end-tidal CO2 so we can have an assessment of, how well they're ventilating, all of those things.
Okay. And so tell us a little bit about how you make a determination in the emergency room about whether someone is suffering from a pulmonary issue or a cardiac issue.
So one way you can tell is, again, looking at the heart tracing, is the person in a normal heart rate? Is it a normal rate? Is it a normal rhythm? What is the heart doing? Is the person respirating and oxygenating well? In other words, is their pulse oximeter normal? Is their end-tidal CO2 normal? Sometimes we'll get a quick portable chest X-ray. I would say those are the main things. And also like vital signs in general.
Okay. And when you have a patient that's suffering a cardiac issue, what are some of their chief complaints?
So obviously, you have the classic chest pain. Another very frequent complaint is shortness of breath. Another very frequent thing that we see is profuse sweating.
And what about respiratory issues?
So there are two things that drive or would drive a person's feeling like they can't breathe. One would be they can't breathe. They're having a problem with the pulmonary system, like as in COVID, or the other thing, and what that means is that they're not able to get good oxygen exchange, right? So you have two things that are at play here. You have the lungs, which do the gas exchange, and then you have the heart that pushes all of that blood with the new oxygen around the body. So both are important. Obviously, you have to have both. And so determining which one that is incredibly important in terms of how you would fix it.
And I want to continue on that discussion, but I want to ask you mentioned COVID patients. As an emergency room physician, have you treated COVID patients?
We are still treating COVID patients.
And so what are some of the ways that you have treated patients that are suffering from illness?
So especially early on, the early variants were much worse in terms of, we would have people coming in with oxygen saturations in the 60s, which is just absolutely terrifying. We would, as I mentioned before, we would put them on oxygen, on the high flow nasal cannula. We found a couple of things in COVID. Early on, we were doing early intubation, and these patients didn't do well. And what we learned over time was that actually, if you don't intubate them and you prone them, that actually helps recruitment of the small air sacs in the lungs, and the patients actually did better that way.
Okay. And so I want to walk again through the physiology of you were talking about the heart pumping and the lungs, so I want to ask to pull up, and not for publishing, just for the witness, Exhibit 2750, please. Dr. Stankus, it should be popping up on your screen.
Yes, sir.
Okay. And correct. And if you could look at 2750, are you familiar with that?
I am.
Okay. And would it help you in explaining the circulatory system to the jury if you were to have this exhibit?
Sure.
Okay. Judge, I'm going to ask to publish, I'm going to offer 2750 for illustrative purposes.
No objection, John. No objection.
Okay. 2750 is admitted for listening purposes only. Proceed.
Okay. And if you, Dr. Stankus, maybe you could step down and pointer up here. That's it. Yeah. I don't think we need to slow. Can we go ahead, and if you need to stop the video at any point to explain things, can you let us know, and I can have Ms. England stop it as well, but if you could just go ahead and play it right now and explain to the jury what's going on.
So it's basically the whole cardiopulmonary system. So you've got the lungs up there, you've got all of the blood vessels.
Oh, sorry.
Yes,
Let's
yeah,
go
that
back.
is
Can we
really
go back to the
really
beginning?
fast. Or I'm
Sure.
really slow.
That's okay.
She might go.
Sure.
Or I can speak up if
If you can.
either
There's
way.
people who consistently do that. We do have a little, thank you. The lapel mic.
Which would you prefer?
I think the lapel mic would be best. This one still charged?
Should be.
See if that works.
Is that working?
Yeah.
Let me see. Hopefully.
I tend to walk away from some-
Okay, is that working?
I think it's better.
Is that better? Yeah, okay.
So explain to us what, if you pause it real quick, Ms. English.
Okay.
So explain to us what we're looking at right now.
So basically, this is just an illustration of your whole cardiopulmonary system. So what it's going to do is it's going to show your lungs in just a second. It's going to show the blue is unoxygenated blood, the red is oxygenated blood. The unoxygenated blood has to go through the lungs in order to have the gas exchange and become oxygenated. Once it's oxygenated, then it can go to the left side of the heart and then be distributed throughout the body. And then the other place where you get the gas exchange, obviously, is in the really small tissues in the capillaries. And I'm just going to, I think you should just let it run and
Okay, great.
so people can see it. So the lungs, unoxygenated, going to the lungs, getting oxygenated, going back, going into the capillaries. You've got oxygen exchange there again, and the unoxygenated comes back to the lungs, gets reoxygenated, gets put to the left side, goes out to the body. It's just a constant cycle like that.
So that's what we're seeing here.
Right. Right. So exactly. So this needs to get pumped. The unoxygenated gets pumped to the lungs. There's gas exchange that occurs. Now it's oxygenated, comes back to the left side, and then it goes up and out through all those red vessels, which are arteries, and it goes all the way down into the smallest little blood vessels, which are capillaries, where the gas exchange occurs again. So it's taking, you get the oxygen from the lungs, and then you pick up CO2 from the tissues that have used that oxygen.
And can you go to that last clip again? The very last part of the video. So right here, where you see that the blood is coming out of you said the left side of the heart?
Yeah.
Okay. And back into the system again.
Back into the system.
What happens if that is not, what happens if there's a malfunction with that?
So your lungs may be working just fine. You may be able to, get air in and out of the lungs, and there can be some exchange here. But if this part's not pumping out to the rest of the body has no way to get that oxygenated blood and then to make that exchange in the capillaries.
And what's some of the ways that you can tell if that's an issue?
So you can tell if that's an issue with the rate and rhythm of the heart. If someone is in heart failure, that's obviously a problem. You can, and then you can see it in oxygen levels in the blood
Okay.
because that exchange isn't happening.
Okay, I want to talk some specifics about this case.
Can I go?
Yeah, you can
Okay.
do that.
Should I, John, should I take this off? Is it gonna?
Okay, you can keep it on. And you can take this down. Thank you. So- So, Dr. Stankus, I wanted to ask you, do you remember when you first got involved in this case?
I do.
When was that?
I believe it was March 2022.
And I want to talk about some of the records that you reviewed in informing your opinion in this case. Did you review Mr. Ellis's medical records?
I did.
And why is it important to review someone's medical records?
You know, we don't often have the ability to do that in the emergency department, but when we can, it's obviously good to have a whole picture of the patient, including what is their medical history, what medical problems do they have coming to the table or to that event.
And what did Mr. Ellis's medical records tell you about his clinical and medical history?
So I believe that what I looked at went back to about 2009, and there were many visits for either drug-related or trying to get help with that, or with complaints of shortness of breath and chest pain. It was a common thread in those medical records.
Do you have an idea of how many times he had gone to the emergency room up to the point of this incident?
I would have to look. So one of the limitations that we have is I don't know for certain that we have all of the records, but of what we do have, I seemed like dozens. I would have to go back and look, but it was a lot of visits.
Okay. And is that uncommon for someone who's, do you remember how old Mr. Ellis was?
Objection, relevance.
Overruled. This is part of his patient history.
So he was 33, and so it would be unusual without some, underlying significant medical condition to have that many visits.
Okay. And have you treated patients that are meth affected in the emergency room?
Yes.
And what are some of the difficulties in maintaining appropriate care for someone who's meth affected?
So in my experience, particularly at St. Joe's and Tacoma General, it has been my experience that
Your Honor,
patients...
I'm going to object at this point with regard to her experiences with unless she's going to go into support, I think he was using force.
Well, I think she's talking about the medical implications of people you are treating who are, well, you said meth affected, I think.
Yeah.
But I don't know if you,
Medically treated.
yeah, and I don't have a problem with that, except I'm not sure what meth affected means in this circumstance. Are we talking about somebody who has an ongoing history? Or are we talking about somebody who is currently under the influence?
It's a good clarifying point, Judge. Let me ask.
All right, so it might be helpful to all of us if we had some better idea of what she meant by that.
And-
Other than that, I'll overrule the objection.
Okay. And let me clarify also, you're not here to talk about use of force issues, right?
No.
How long ago were you a police officer?
Well, to put it in perspective, I didn't have a cell phone and we weren't using internet, so it was over 30 years ago.
And does that in any way color your testimony today?
No.
And so, I guess when I was using the term meth affected, I wanted to ask you about patients that are coming in that have methamphetamine in their system. What are some of the chief complaints that you've seen?
So psychosis or delusions, agitated behavior, high blood pressure, Unfortunately, because the blood pressure can get so high, sometimes we see head bleeds, fast rhythms, heart failure, all of those things.
Okay. And is that something that you had to treat often in the emergency room?
Yes, particularly at St. Joe's and Tacoma General. I would say a good 20% of that patient population is, those visits relate to drugs and or mental health issues.
And in terms of, along those same lines, what are some of your experiences and the difficulties in someone who has those issues in continuity of care, like continuing care, consistent care?
So I would say that in my experience, there is not great continuity of care, and I would say that that's in part due to a lack of good resources in caring for those issues.
Okay. And in terms of Mr. Ellis's records, what did you specifically take note of with him? You talked about some of the symptoms and some of the things that he had, but what are some of the other things that you may have seen in those?
So there was recurrent pericarditis. There was an incident where he came into the emergency department and was complaining of chest pain. He had elevated troponins there. Cardiology was involved trying to determine, is this a heart attack? Is this something different? There were multiple episodes of what I would call a very high heart rate. As I recall, there was one where his heart rate was 206 when he came in, and multiple episodes of high blood pressure, and then also talking with providers about his drug use, how it's been problematic, and makes some of his hallucinations and things like that worse.
Okay. And you mentioned pericarditis. Am I saying that correctly?
Pericarditis.
Okay. Pericarditis?
Correct.
Okay.
So peri, which means around, card, which means heart, itis means inflammation. So inflammation around the heart.
Okay. And I want to ask you, what were some of Mr. Ellis's, and that's inflammation of his heart, right?
It's of the lining of the heart.
Got it. And what were some of his chief complaints when he had that issue?
Chest pain and shortness of breath.
Okay. Do you remember how he specifically couched in the medical records how he was feeling shortness of breath?
I would have to look at some records to be specific.
And you mentioned the STEMI, is that right?
Yeah, sorry. So that's an ST elevation MI, which is just the classic. You have, a big change in your EKG, which shows that you're having a heart attack.
Okay.
You can have a heart attack without that, but that gets our attention, and usually gets someone to a cath lab within 10 minutes or so.
Got it. And you also mentioned elevated troponins.
Yeah, so when the heart is stressed or strained, either it's not getting enough oxygen or there's some sort of blockage of a blood vessel to the heart, and that part of the heart is starting to die, the heart will give off an enzyme, or even sometimes if it's in heart failure, it'll give off an enzyme saying it's injured, essentially, and that's called troponin.
And within the records, do you remember the last time that Mr. Ellis was complaining of shortness of breath or labored breathing?
The last time I remember was, I believe it was a mental health visit, not an emergency department visit.
And what do you remember about that, Ray?
I remember that I believe that the treatment session had to be cut short because he was complaining of some significant shortness of breath, and that I don't even remember who the provider was, but the provider said, look, I think you need to go to the closest urgent care center and get checked out.
Well, did you ever review any urgent care records?
I looked, I didn't see any.
Okay. Is that part of the issue of being uncertain if we have all of Mr. Ellis's records?
Yes. Because I assume that he would have gone, given the description of how he felt and the concern for the, from the provider.
And that was a session that took place in late 2018, is that right?
Yes.
I do want to quickly follow up on some of the symptomology that you discussed. I want to show you what's been marked as exhibit. Defense exhibit 2013. It's a big one.
Yeah.
And those are the certified medical records of Mr. Ellis. Have you reviewed those?
I assume so, yes.
Okay. And then there's a lot there.
Yeah, there's a lot to go through.
And what hospital is that at?
This would be a multi-care Tacoma General.
And that's the hospital you worked at?
Yes.
One second. Sorry. When you flip to page on the bottom, it should say 3342. What's the date on that?
No, my eyes are definitely getting older. Small print. No, I'm okay. I got it. I believe this is February 24th, 2017.
Okay. Sorry, I'm in my copy of it, so I wanted to ask you to read a portion of it. Can you read? It has a history paragraph there, correct?
Yes.
Can you read that out loud,
The whole thing?
please?
Okay. Manuel E. Ellis is a 30-year-old male with a history of asthma, anxiety, chronic viral pericarditis, recent pneumonia, and IV drug abuse. He presents to the emergency department with complaints of chest pain. He states that since being seen in this facility as an inpatient, his symptoms began to improve. However, his chest pain and shortness of breath became severely exacerbated this morning upon waking. The patient describes it as a feeling like trying to breathe underwater, unquote, and is similar to the pain he experienced with his recent pneumonia and pericarditis. Says he woke up drenched in sweat. He reports that he finished his antibiotic course 3 days ago. He has no known allergies.
And are those some of the symptoms that you've been describing to us that people feel when they're having cardiac issues?
They can be, yes.
And in this instance, it was pericarditis, right? Or it was some type of cardiac, something related to it. Maybe it was atypical chest pain.
Let me just look at their diagnosis here.
Well, if you start, I can help you as well.
Oh, sure.
3349.
Oh, that helps. Let's see. So, health-acquired pneumonia, pericarditis, elevated troponin, and history of pericardial effusion.
Okay. And that's a record from 2017, right?
Yes.
And based on your review of some of the other medical records, including autopsy, did Mr. Ellis's health conditions improve or get worse since that date?
Well, they didn't get better
Why?
because he continues to complain of very similar issues. And I guess the other thing that I would say is that he reported daily use of methamphetamine, which we know is associated with pericarditis, with dilated cardiomyopathy, with left ventricular hypertrophy, which we did see on the autopsy.
Okay. So I want to ask you about the autopsy. I can take that now. Thank you.
Oh, sorry.
It's okay. Maybe moving that
You
microphone.
know what? I'm going to turn this off and just use this.
Yeah.
And if I have to get back up, I can turn this off.
So I'm going to hand you what's been marked as 2583, defense exhibit 2583. I'll give you a chance to review that. Ready?
Yes.
Okay. And what is that document?
This is the autopsy or medical examination report.
And did you review that in formulating your opinion in this case?
I did.
Was it one of the first documents you reviewed?
It was the first document I reviewed.
And could you flip to the page that includes the findings?
Sure. Yeah. Okay.
And
Exhibit 2583 was slightly different than another exhibit that was also the autopsy report because it contained, as I understand it, this one also contained the toxicology report.
correct.
But this exhibit has never actually been admitted.
It is
It was acknowledged by Dr. Clark, I
not.
think.
It was.
All right.
I believe in his testimony he said, well, it doesn't include my graph, his chart, and blood reports. We had that included.
Right. And that's 2583.
That's 25.
But it's never actually been admitted.
And so this is a record that you relied upon in formulating your opinion in this case.
Yes.
And what stood out to you about this record?
Well, the very first thing that stood out to me, let me just read it. Well,
I don't know if she's going to read it to herself or aloud, but given that the part she's reading, I think, is a part that's already been admitted. Any reason not to admit 2583? State of an objection?
Completeness, Your Honor, I think that it also requires the admission of the supplemental report. This is the autopsy and the supplemental report.
Was the supplemental report previously admitted? I don't know.
No, it wasn't, but it should both be admitted if it's going to go to Dr. If you're going to admit this exhibit, the autopsy, because the autopsy is not complete without the supplemental report.
There is no supplemental. The supplemental report was their expert report that they had in draft afterwards. This is the actual medical record.
Isn't that correct, Ms. Akes?
They're both the reports of Dr. Clark as it relates
Well, I understand that, but the supplemental report came
after he received other information.
more than a year later, right?
After he received all the information.
And we was already, at that point, he was retained by the state, right?
Understood.
All right. So as under the rule of completeness, no, I'm not going to make that part of it. Any other objection to this?
No, Your Honor.
Okay, 2583 is admitted.
And let's actually publish it for the jury. And we could have the ability to zoom in a bit on the last paragraph. Could you read that out loud?
Should I stand?
No, you can.
Okay. The whole last paragraph? Okay. Autopsy examination does not reveal an anatomic cause of death. The methamphetamine concentration is well within the fatal range and could have caused the death independently. However, if it had, one might expect that it would cause a cardiac dysrhythmia, such as ventricular fibrillation, and would produce sudden death. Yet in this case, upon arrival of first responders, the decedent was close to respiratory arrest but still had a sinus cardiac rhythm. Thus, it is likely that progressive hypoxia as a result of physical restraint, positioning, and the placement of a mask over the mouth is a significant factor, and possibly the most important factor. Death, therefore, is certified as being due to hypoxia as a result of physical constraint with contributing conditions of methamphetamine intoxication and a dilated heart. It is unlikely that this death would have occurred due to physical restraint alone without the contributing conditions. Furthermore, an argument could be made that the extremely high methamphetamine concentration should be considered the primary factor.
So one of the things that's noted in there is sinus cardiac rhythm. You see that?
I do.
And what does that mean?
That means a normal heart rhythm.
Can we pull up? I believe it's already been submitted as illustrative purposes. 562. That's right. Has it already been illustrated?
I don't think so. Okay, 562. Yes, I do have 562, offered admitted without objection for illustrative purposes only.
Can we pull up 562? So is this what you're talking about?
Yes.
Can you step down and make sure your microphone's on too?
I think it's on. Is it working?
And can you explain? Okay, so it said the autopsy report said sinus rhythm, and explain to the jury again what that means.
So this is the classic, what everyone's healthy heart should look like. You have this little bump here, which is the top part of the heart that's firing, and then there's a little pause, and that signal is transmitted down to the lower part of the heart, and then this is the ventricle firing, and then this is the relaxation of the heart. It waits until it's time to beat again. You get the signal from the upper part, there's a little pause, you get the bottom part that fires, it relaxes, and it goes on and on like that. That would be normal.
Okay. And so one of the things, the next thing I'll ask about, you can have to see again, is Exhibit 24, which has already been admitted. Are you familiar with this English you should take it now? Okay. Are you familiar with Exhibit 24?
I am.
And what is that?
This is the pre-hospital care report from Lieutenant Wilson.
Okay. And did you review that informally in your opinion in this case?
This was the second thing I looked at.
And what stood out to you about the pre-hospital care report?
Well, frankly, I wasn't sure if it was from this case because what I was seeing was not normal sinus rhythm.
Where were you seeing not sinus rhythm?
So the very first rhythm strip that is seen as soon as Mr. Ellis was attached to the life pack.
Okay. And can we, with your permission, can we publish Exhibit 24?
Yes.
What page is that seen on?
It would be the Bates 0445.
Okay. And is that the rhythm that you're talking about? Or sorry, can you point out to the jury which rhythm you're talking about?
Let me just make sure that's right. It would be the top one.
Okay. And so you saw that rhythm and you could right away indicate that it was not.
I identified it right away as what it was, which was not normal sinus rhythm. It was atrial flutter with variable conduction.
And then the next thing I want to ask you about is, well, what's your understanding of where this data, where this EKG strip comes from?
From the life pack that was at the scene that was attached to the patient, Mr. Ellis.
Okay. And I want to pull up the life pack as well as exhibit 2739. And is this the life pack data that you're talking about?
It looks like the beginning, there's nothing on it yet.
Sure. And could you step down from the jury and I want you to explain, you can pause it whenever you want, explain to the jury what we're seeing with Mr. Ellis and talking with him. And Ms. English, if you could scroll forward to the portion that actually starts displaying. So sorry, that's that initial rhythm that you're talking about that was on the
Right, so they're probably still attaching things, that's just some artifact, and then this is the original rhythm that we see.
And if we could play it in English,
So I would pause it for a second.
sure.
So this is not as good of a rhythm strip as you'd see in the emergency department, but it's good enough to show what the underlying rhythm is. And what you can see is you have these pretty similar looking regular bumps here. And as Lieutenant, I think Lieutenant Wilson testified that those were like little atrial bumps. So what you have is, the first thing you see is you've got this rhythm from the bottom part of the heart, and now the top part is saying beat, 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 but there's no beat. And then, bam, there's the bottom part finally pumps. There's some artifact there, so it's hard to tell, but these are probably going along at that rate. And one of the things that you notice, and why this looks like atrial flutter, as opposed to just the upper part of the heart wiggling around, is that it's regular. So an atrial fibrillation is not regular. By definition, it's irregular. By definition, an atrial flutter is regular. And what that means is that, I think we have an illustrative that I'll show you, but what that means is that there's this regular rhythm that's going through the top part of the heart. Normally, what happens, and that's happening, so each one of these boxes is a time, right? So across here is time. And one of the quick cheat things we do in the emergency department is we say, okay, from this tiny box to this next box would be 300 beats a minute. To this next box would be 150 beats per minute. To this next one would be 100, and then 75, and then 60. So it's a really quick way to just, at a glance, know how fast or slow something's going. So I can tell you right here that this is going almost 300 times a minute. I think Lieutenant Wilson said it was about 200, but it doesn't matter. The underlying rate of atrial flutter is always between 240 and 340 beats per minute. On average, it's about 300 beats per minute. So what that means is that there aren't a lot of these going on, but there's a lot of activity in the upper part of the heart saying fire. And what that means is that there's something there's an electrical problem, that the top part of the heart is not communicating right? I think he described it as, the lights are going on upstairs, but there's a problem in the basement. They're not coordinating together. So, so even though the heart is telling him to beat 300 times a minute, it's not. It's we'd have to march this out and look. But if you want to just keep going, that's kind of a basic explanation of what's going on there. But stop just for a sec. But that is definitely not normal sinus rhythm. Here it's the same thing. We describe this as kind of sawtooth. These all look the same. That's not fibrillation. That's flutter. And so, and when I say variable conduction, what I mean is that sometimes these beats get through, sometimes they don't, and that's going to create a very it's going to cause a lot of problems from the heart that we'll talk about in a minute. But it means that sometimes it's going to go fast, really fast. Sometimes it's going to go really slow, depending on whether or not that impulse is getting through. So here it's pretty slow. It's pretty slow, pretty slow. This one's fast, right? So this one is 300. This one's going like 100. This one is going like 75. Go ahead. In terms of a rate, if it were to continue that way. But you can't do that because it's not regular. It's fast. It's fast. There's some escape rhythms in here. Can you stop it for a second?
Yeah, what's an escape rhythm?
So an escape rhythm, so this is the lower part of the heart beating, but it doesn't look like that. These are narrow. That's a normal conduction through the heart. So normally when you get an impulse from the top of the heart, it goes to the next node that's in between the top part and the bottom part, and when that node fires, it goes through a thing called the Purkinje system. And what that is it's a really rapid electrical system that goes all the way around the ventricle of the heart so that it makes sure that everything is coordinated and it all beats at the same time. When it's wide like that, that's not happening. There's a delay, and so it's not as effective. And it also happens when the heart is irritated. So the heart's actually, it's pretty smart design actually. So, if the heart stops working the way it's supposed to, just about every single cell in the heart has its own ability to generate an electrical impulse in case it's in trouble, because it's the most important thing in our body, right? Like, your heart stops beating, you're not gonna live very long. So that's why that happened. That means that there's something going on. He's going really fast, but that's like almost 300 times a minute. Not quite, maybe 250 times a minute if you were to stay that fast. Keep going. So this is all fast, really fast.
Is it normal at any point?
No. It's variable. It's all over the place.
And what does that mean, it's variable?
It means sometimes it's fast, sometimes, so go ahead and stop. So normally in flutter, what you see is like this. So there's 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3. That doesn't happen in AFib. You don't get this regular beat to beat interval that's regular like that. You only get that in flutter. And so it's trying to beat, and in this one, it's trying to beat at least twice in between. So what we would call that is a 2-to-1 conduction. And that's what we normally see in flutter. When someone comes into the emergency department and they say, hey, I don't feel good, I feel short of breath, I have chest pain, and I look at their EKG and it's like, we put them on the monitor, I can just look and they're going 150. I'm like, that person's in flutter, and it's regular, they're going 150. That person's in flutter and they're in a 2-to-1 block. I mean, you can almost just know that by looking at the rate, looking at their symptoms and that sort of thing. So it's actually kind of regular there, which is good, and it's a rate that would be, not bad. It still has problems, but not bad. Keep going. That's a problem. Stop. That's a huge problem. When I see this, I don't get nervous very often in the emergency department, but when I see this, I get really nervous, like really scared. Bad things are about to happen. So The heart is trying to beat, 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 nothing until here. Okay, bam, I'm gonna beat. That's a long time to go without your heart beating. That's a really long time. That's not good.
What does that tell you about what's going on in the heart?
This is sick heart. This is a cardiac problem. This is not normal sinus rhythm. This is not progressive bradycardia. This is not PEA. This is a rhythm, and that's what Lieutenant Wilson described. He said he was very concerned because when he got there, he felt an irregular rhythm. At the time that he was feeling the pulse, it was slow, but then it got fast, but then it was slow, and it was very irregular, and that's what we're seeing here exactly on the life pack. And I believe that he said that was even before they got him on the pads, because there's so much going on. That job is even more stressful than my job. You've got to get there. You're putting the person. They're bagging the person. They're trying to put on the pads. They're trying to get IVs. They're trying to assess the patient. They're trying to take the pulse. So I don't even think that this got attached until, I'll have to go back and look, but about 3 minutes into it. So keep going. Same thing, pretty long pause. But but it's speeding up again. So long pause, speeding up again, but very irregular. These are pretty fast. So he goes from being pretty slow, now he's really fast again.
Can I ask you a quick question?
Sure.
Is that something that you ever see in the emergency room with someone who's having a respiratory issue, a pulmonary issue?
No, so as has been explained, I believe, having read the transcripts about what happens, is when you have a pulmonary issue, and what we see, and that we see it a lot, whether it's when we're intubating someone and we can't get the airway right away, or someone is having a seizure and they stop breathing. What we see is, their heart will be ticking along, and then it starts to pretty quickly start to drop. So it'll be like beat, 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 beat. And that really gets our attention, because what we know is going to happen pretty quickly after that is that there's going to be no beat.
And that's, sorry, go ahead.
No, and it's going to be, and so, even at that point, once we fix the problem, you get the airway, you fix the seizure, they start breathing again, they're going to go back to normal on their own.
And what are you seeing in this rhythm in terms of beat, beat, beat?
Well, again, I mean, all you have to do, anyone, you don't have to be a cardiologist or an ER doc to look at that and know that that's irregular, and that there's like long periods of time between beats, and then there's short periods of time between beats. That this is slower and this is faster. You can keep going if you want. Same thing, we're going pretty fast here. About 100, a little bit more of a pause. Got some escape beats. Things are getting a little bit more erratic here. That would be, if that just stayed that way, would be a rate of about 250. Keep going. It's pretty fast. It's irregular. There's escape beats. The heart's really irritated at this point. Same thing. Faster, slower, faster, slower.
And can I ask you a question?
Sure.
Is it irritated because it's not getting oxygen?
Yes,
And why is it not getting oxygen?
because it's not pumping effectively. So there are a couple of things that I think are important to understand. One is when you have a dilated cardiomyopathy, what that means is that the heart is stretched. And when that happens, it doesn't pump as effectively. Sometimes that's severe, sometimes it's not, but any dilated heart is not going to pump as effectively. With the left ventricular hypertrophy, you have less space in there, but then you also have less ability to relax. So you have a lower ability to pump and a less ability to relax to allow the filling. And so, just that by itself could cause heart failure. And we know that there was heart failure before this happened based on Dr. Clark's testimony. And this rhythm alone, I would expect that to exacerbate it. So when your heart is trying to pump faster, if you can imagine just a pump, in order for it to be effective, it has to fully fill and then pump in a coordinated way, right? So if it's going really fast, sometimes we call that a high cardiac output that can lead to failure in and of itself because there's not time for it to fill. When you have something like this, and we'll show the maybe
Illustrious, you want to do that now?
maybe we should finish this first, but the other thing that happens in decompensated, and I'll tell you what I mean by that in a second, but when you have decompensated atrial flutter, so the person is going fast, they're coming in, they're saying, I'm short of breath, they have a low blood pressure, they're hypoxic. Oftentimes, one of another things that happens is, so when the top part of the heart beats, there's a valve between the two, right? So there's not backflow; it's just a pump. It's not that complicated. So the top part pumps, the valve opens. There's a pause as the bottom part starts to pump. That valve closes. In flutter, sometimes what can happen, we've seen this when we put the an ultrasound probe on someone's heart. Every time the top part is making that circuit, it's causing that valve to open. So the valve, I can't even do it as fast as I need to show you. So let's say that rate is 250 times a minute. That's like the thing is just opening and closing. There's no time for the heart to fill. So that's what causes heart failure. And so let's just keep going with this. Beat, 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 fire, beat, 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 beat. This is not fib, this is flutter. This is straight up atrial flutter.
And what's the difference between, why is that important to you that it's flutter?
So this is how we define this in the broad sense. This is a tachycardia, even though this is not it's not firing quickly. It's called a supraventricular tachycardia. So supraventricular meaning the area above the heart in the atria. So it's a circuit that's happening in the top part of the heart, and it's going like this, and it's trying to fire that fast, but that signal is not getting through. And so here this is starting to, let's see, that's a pretty slow rhythm. Go ahead. Or rate, I should say. It's a fast rhythm, it's a slow rate. Variable, slower, then faster, then slower, then faster.
Can I ask you a couple questions?
Sure.
Sure. Have you ever seen that type of rhythm without a pulse?
No.
Wow.
This type of rhythm doesn't happen without a pulse. So when you're looking at PEA, you're talking about an organized cardiac rhythm. So you may see something that looks like normal sinus rhythm or normal, like, the little pump. You may see V-fib, you may see V-tac. I've never ever seen this in PEA. I can't find an example of this as PEA anywhere. It doesn't exist as PEA.
And when you were
And I would also add that the whole time that that Lieutenant Wilson was taking care of Mr. Ellis, until it was time to do CPR, he said he felt pulses. So just, from his description, from what I know as an emergency physician, what I had never seen as an emergency physician in any of my experience or training or in textbooks, this is, and again, it's kind of a moot point because Lieutenant Wilson is there and he's feeling this and he's feeling that it's irregular and it's fast and it's slow and it's fast and it's slow.
So let me ask you a quick question, follow-up questions. So the atrium's trying to fire, right? Here, the supraventricular,
No, that's right.
supraventricular rhythm.
Right.
That you have the atrium trying to fire, and Lieutenant Wilson described it as like upstairs trying to communicate with the downstairs. And the term perfusion, what does that mean, perfusion?
So perfusion is the ability of the heart to get that oxygenated blood to the body.
The pumping of the blood.
The pumping of the blood throughout the body.
That we saw on that.
Everywhere, including to itself.
And what happens when that is not happening in a I guess normal fashion, or in a rhythm like this?
So it leads to heart failure. If you're already in heart failure, it's going to make it worse. Can lead to cardiogenic shock, which is what I believe happened here.
And that's what can lead to also an oxygenation issue.
Absolutely. So you can become hypoxic. So hypoxemia just means level of oxygen in the bloodstream. That can happen either because your lungs aren't working, you're not breathing, or your heart's not pumping.
Okay.
Or it's not pumping effectively, or it's in an arrhythmia where it's variable.
Do we want to finish looking at this?
Sure.
Play through.
Trying to beat fire, beat fire.
This is all still atrial flow, correct?
Correct.
And do you ever see any other rhythms on these strips?
Yes. It's hard. Let's see. The other thing that I want to say about progressive bradycardia is that it is what it sounds like. It happens pretty fast. So, you're compensating for a while up here, and then like you're compensating, and then it's going like this. It happens. It doesn't happen over. It happens pretty fast, and it doesn't do one of these. It goes down, and then you go into PEA.
And that's what you would expect to see if it was a respiratory issue.
Correct.
Okay. So when someone discusses PEA, or that they're pulseless and it's bradycardic, the PEA that they're discussing, that's coming prior to arrest. Well, sorry, PEA is arrest.
Right. Yes.
It means you don't have a pulse.
Right. So there are two terminal rhythms, essentially. There's pulseless electric activity, which, by the way, means truly pulseless. It's not a low blood pressure. It's not so when I diagnose pulseless electrical activity in the emergency department, and we put a probe on the patient's heart and on the outflow of the heart, and we can see on the monitor that there's some sort of rhythm, whether it's a sinus rhythm or whether it's a V-fib or something like that, V-tac, and what we'll see is like nothing. We see there's not effective squeeze. There's nothing coming out of the heart. It's truly pulseless. Sometimes people we'll call pseudo PEA if there is a pulse, but it's not pulseless PEA. So the terminal rhythms are either you have some electrical activity but absolutely no effective pump, or you just have a flat line, which is called asystole.
Okay. I want to pull up 2749 quickly. You guys see. Yeah.
Okay, we'll take our morning recess for 15 minutes, ladies and gentlemen. Please do not discuss the case among yourselves with anyone else. Thank you. Okay, we ready for the drinking? All right. So you're going to exhibit 2749, I think that's what the number is. Continuing, you ready, Mr. Conrad? Are council all familiar with 2749?
Yes, Your Honor.
And you're offering it for illustrative purposes only, right? So understanding there's no objection? 2749 is admitted for illustrative purposes only. Proceed.
So, are you familiar, you're familiar with this video of Dr. Stankus?
Yes.
Okay, so can you kind of walk us through what we're about to see?
Yeah, so normally in normal sinus rhythm, that, as I think you guys are probably very familiar now with the idea that there's an impulse that starts here, and it causes the atria to contract, and then it stimulates the AV node, and then that runs through this very fast fiber system, and then the bottom part of the heart contracts. In atrial flutter, it's a little bit different because it's this re-entry. It's a circuit that's happening up here that's causing. It's a regular circuit, and that's what we're showing.
Okay. This is the heart.
So that's normal. That's what it should look like.
And that's normal sinus rhythm.
Correct. So in flutter, you see how fast that tachycardia is up in this upper part, this isn't responding every time. Again, in even a sick heart that's in atrial flutter, there's normally regularity to it, rather than sometimes it's regular, sometimes it's not, sometimes it's fast, sometimes it's slow. The other thing that I was trying to explain also is that, especially in someone who is decompensated, one of the reasons they're decompensated is because there's also like opening and closing of this valve that shouldn't, so it's allowing more backflow in addition to the problems with fulfilling of the heart.
What do you mean by decompensated? You have to explain.
So yeah, I'm sorry. So as an example, if I go running and I have an increased demand, my heart rate might go up to 130 something. I'm running along, it goes up to 130 because I'm compensating. If I'm running and I am getting ahead of my skis, so to speak, and I'm up at my max heart rate of 190, if I can't maintain that for a long time, and someone who isn't running or whatever, their heart's going too fast for them to fill, then you start to get into what's called cardiogenic shock, where shock just means a lack of perfusion and a lower blood pressure and that sort of thing. So that's what I mean by decompensated. You're not able to perfuse, you're not able to maintain a blood pressure, and that's when things start to go badly.
And when we're seeing this atrial flutter, is that an animation that depicts what we're seeing within those EKG strips that you just walked us through in the light pack?
So sometimes it is. So here you can see there's like one of those isn't a P wave probably, but they're all coming at a regular rate, or it's embedded in there. But regardless, it's this regular rate that you're seeing, and you can see that on the animation. And it's regular because every say third pass of that impulse is going to stimulate this. In Mr. Ellis's heart, sometimes it's like stimulated, or sometimes it's just going around, and then finally it stimulates, and it's just incredibly variable.
Why? What difference does that make?
Well, it's incredibly important because if you have an electrical problem like that, a structural electrical problem like that, the heart can't do what it needs to do in order to stay compensated. So it can't do what it needs to do. If the heart needs to go fast because it's got an increased demand, and the thing is just like circling around up here in the atria, and it's not making it down, then the heart can't beat fast enough.
And what causes that type of electrical problem?
So a lot of times when people have this problem, it's because there's changes in the heart cells themselves, in the structure of the heart itself. So someone who has remodeling of the myocytes from chronic meth use will have inflammation and fibrosis and other changes in the cells of the heart that cause these electrical issues. People who have dilated cardiomyopathy can go into these rhythms and have these issues. So it's a structural change in the heart that's causing an electrical problem.
So the animation that we're seeing here with atrial flutter, that's an electrical issue, right?
Yes.
Does Mr. Ellis just have an electrical issue, or are there other things also?
No, so you have thickening of this wall, so you don't have as much space in there to fill. You have dilation of the heart, which means that it's not going to be able to contract as forcefully. So you've got a bunch of stuff going on.
So it's not only electrical, it's how the heart is mechanical?
Sure. That's a good way to put it.
Okay. And then how does the meth also play into this dynamic?
On a toxic level of meth, what's going to happen is the first thing that's going to happen is you're going to get a massive release of catecholamines or adrenaline. You're going to have we call it a hyperadrenergic state, but all that means is that you're going to have this big dump of all of the things that get you excited, get your blood pressure up, get your heart rate going really fast. So from a cardiac standpoint, that happens. You also get constriction of the blood vessels around the body, including oftentimes around the heart. And that just makes it worse. So you've got this super high rate that anyone who's on a toxic level of methamphetamine is going to have a very high heart rate to begin with.
And I want to ask you a couple other, I think we're done. Can we pull back up the backpack data in exhibit 2739, please? Thank you. So we were talking about, can we scroll back again just a little bit? Thank you. So the rhythms we're seeing there is that atrial flutter that we're seeing. And then I want to ask questions about, let me ask you, what's your understanding of what the paramedics are doing at this point with Mr. Ellis? What his condition is?
So my understanding, based on particularly the testimony transcript, was that as soon as they got to Mr. Ellis, even before he was taken out of restraints, they saw that he was having shallow breathing and started using the bag valve mask to assist him. So a bag valve mask is, we use it commonly in the emergency department even, so it's hooked up to oxygen, so it's got a big reservoir of gas in it, which is typically all oxygen, and it's got the mask that seals over the nose and mouth, and then you're able to give big breaths. So you're making sure that you're giving big breaths, you're giving 100% oxygen. So he's getting that for several minutes before, I believe, the life pack or the pads were attached, and those pads pick up this electrical impulse and create this life pack data.
Okay. And so he's getting oxygen through that BVM, is that right? The bag valve mask?
Yes.
Okay.
Essentially, Lieutenant Wilson he's breathing for him.
And so you mentioned shallow breathing. Does that tell you whether it's a cardiac issue or a respiratory issue?
No.
Why not?
Because, again, you can have cardiogenic shock where your heart is doing something that is not allowing perfusion, it's not allowing adequate blood pressure, it's not pumping effectively, it's not moving blood around, and that can lead to this condition.
And what about one other thing that Lieutenant Wilson noted was the Glasgow scale?
Glasgow-Coma scale.
Glasgow-Coma.
GC, or just say GCS, it's easier.
GCS, way better.
Yeah.
Scale of 1, 1, 1, that he's unresponsive. Does that tell you whether it's cardiac or respiratory?
No.
Why not?
Again, this is an unconscious, so it basically means that the person is unconscious. And a lot of things can cause a person to become unconscious, including respiratory failure and including cardiac failure, essentially.
Okay. And so, you're talking about Mr. Ellis getting oxygen through the BVM.
Yes.
And have you used a BVM before?
Many times.
Have you resuscitated people before?
Yes.
And given your training and experience that you would be records, would you have expected, do you believe to a reasonable degree of medical certainty whether Mr. Ellis, if his issue was respiratory in nature, he should have gotten better?
Yes, and I believe that, again, Lieutenant Wilson talked about that and fully expected that with this resuscitation, he would be able to ultimately transport Mr. Ellis to the emergency department.
So what does it tell you that when he's getting oxygen and he has a pulse and not getting better?
So again, that's just, that's illustrating again the idea of heart failure and cardiogenic shock being the main problem. You know, I was kind of explaining what happens in respiratory failure where, so you're just ticking along, there's something that happens, you have a seizure, you can't breathe, we paralyze you because we're going to put an airway in, you can't breathe, and there's a little bit of an uptick, not much, so you're going a little bit faster and you're cruising along, you're doing okay, and then all of a sudden you start ticking down, and it's something that we see. It's pretty dramatic when it happens. You're ticking along, and then bam, you're dropping really fast and progressively, and then you hit PEA. And even when we see that, if it's a pure respiratory issue, we should be able to rescue that person and successfully, even if they're in that very first part of the PEA. Depends on how long it goes, of course, but within that first period, we should be able to resuscitate them.
And do you see any sort of PEA leading up to Mr. Ellis's arrest here?
There's no evidence of that.
And when you were formulating your opinion in this case, did you ever formulate that based on the fact that Mr. Ellis did not have a pulse when EMS arrived?
I'm sorry?
Sorry, it's not a very good question. So when you formulated your opinion in this case, did you ever assume that Mr. Ellis didn't have a pulse when EMS arrived?
No.
Why not?
Because they said he had a pulse, and I looked at the life path data, and that's not a rhythm that is associated with PEA.
Okay. And what's your understanding of how long Mr. Ellis had a pulse until?
I believe it was something on the order of 6.5 minutes, or 5 or 6 minutes, or maybe even a little bit more.
And when you formulated your opinion in this case, did you ever base that on the fact that Mr. Ellis was in normal sinus rhythm?
No,
Why not?
he wasn't.
I want to go back to the autopsy report, please. Sorry, I should tell you this English word. 2658, please. Sorry. 2583. I don't know my word number. 2583. Is that right?
Yes.
Can we zoom in on that last paragraph? And can you, again, point out what you found concerning about this autopsy report, giving a review of the EKG data, the EKG data, and Lieutenant Wilson's test?
Well, the first thing is that the idea that if this was methamphetamine induced, that it would be ventricular fibrillation that produced death, which is not true. There
Are there more ways that people that have methamphetamine use that?
yes, like this.
And the next sentence there, yet in this case, upon arrival, first responders, the deceased was close to respiratory arrest cardiac rhythm.
Correct, and that, again, when the second document that I looked at was the EMS report, the very first strip I looked at, I had to double check and make sure it was the same case. It was a big disconnect.
Because that's the science cardiac rhythm.
Correct.
I want to go back and cover one last thing about the EKG. The light back there, 2739, please. And if we could scroll. Talk about some other rhythms that were present during this EKG data. What was another rhythm that you saw in this EKG?
So there was a run of what looked like polymorphic VTAC that was shocked.
Okay. And I think that's around 12:02:04.
Yeah.
Yeah.
Yeah, that's it.
Can we, sure, can we scroll back? Sorry. Yeah, can we hit play there, please? So, explain to the jury, sorry, stop real quick, please say which name. So, what's happening now?
So they're probably doing CPR. So just keep going.
Keep playing.
Yeah.
I just want to get you up.
This is what.
Pause it.
Keep
Keep going.
Yeah, keep going. Okay, so can you go back one? I'm sorry. Go back one because, okay, keep going. So what I want you to show is where the CPR stopped. It's marked on there.
Let's play from there. So we're looking at CPR there, is that right?
Yeah. And one thing I want to point out is we don't, just stop it for a second, please. When you're doing advanced cardiac life support, you don't want to stop doing compressions. You want to keep doing the compressions. And so we have no idea what's going on underneath of this, because in CPR, what you're getting, you've got to leave the patient alone to be able to see what's going on. What you're seeing is CPR. So what rhythm Mr. Ellis is in underlying that, we don't know. So briefly we'll stop during this and check a rhythm. And similarly, after you give a shock, the teaching is that you don't even wait to see what's going to happen. You immediately go back to CPR,
Okay.
just as an aside. Just keep going. So this whole thing here is where they're leaving Mr. Ellis alone, and on the small little monitor that Lieutenant Wilson has, he looks at this and he decides that this is what we call torsades for short, because I can't pronounce French, twisting of the points. And so you see that there's like this small, big, it's the twisting of the points. You can see it's almost like it's got that sort of pattern there, which is, I would say that is consistent with torsades.
Okay. And is, can we, without publishing it, can we show Dr. Stankus 2748?
Oh, no, I can see it.
Yeah. Okay. And what does that depict?
So kind of a textbook illustration of torsades and what we see on the life pack data
Okay.
in comparison.
And is that comparison helpful to illustrate to the jury what the comparison between Mr. Ellis's EKG and textbook torsades?
Yes.
Your Honor, I offer 2748 for lesser purposes only.
No question. No objection.
2748 is submitted for listener purposes only.
So can you explain to the jury again what we're seeing?
So it's what we call a polymorphic ventricular tachycardia. Polymorphic just meaning they don't all look the same. Poly is just many. So morphic is form, so many forms. So you can see that, you know, some of those are smaller, some of them are bigger, and it's kind of doing this characteristic pattern of torsades.
And have you ever given epinephrine?
Many times.
Have you ever seen epinephrine cause torsades?
No, it's not a known cause of torsades.
What's the importance of this torsades rhythm?
One, that it's shockable, and very unfortunately, that shock didn't change the outcome. But it's a shockable rhythm that is unusual. I mean, we see it occasionally, but it's not a rhythm that we see incredibly frequently. It can be caused by drugs that prolong what's called the QTC interval. It can be caused by severe electrolyte abnormalities. It can be caused by structural heart disease like cardiomyopathy. It's just not something that we see incredibly frequently.
One of the questions that I'm asking, the next couple of questions are about the term positional asphyxia. Are you familiar with that term?
I am.
And did you consider, well, how are you familiar with
Well, it's an issue in this case.
And did you consider it in rendering your opinion?
I did.
And what are some of the reasons that you don't believe that positional asphyxia caused this?
So, again, if this was caused by positional asphyxia, the patient still has a pulse, still is breathing, even shallowly. I would expect to be able to rescue this patient. We know that the end tidal CO2 was such that, and what that means is that it's a measure of how well someone is ventilating. It's how much CO2 is being removed from the lungs. We know based on the LifePak data that shows that the aggressive respiratory resuscitation efforts that were being made were effective. They were effectively breathing for Mr. Ellis with 100% oxygen. And that was going on for a period of, again, about six and a half minutes. And not only did he not get better, as one would expect, but he continued to decline in terms of his cardiac rhythm and what was happening.
What about the rhythm?
So again, that is not. So we don't see PEA when Mr. Wilson or Lieutenant Wilson gets there. He is in an abnormal supraventricular tachycardia with variable conduction. What else? He doesn't have that classic decline in terms of the heart rate that we see with respiratory failure. And the PEA that we do see is really at the end of this resuscitation, which is PEA or asystole are terminal rhythms for all of us when we die.
Are there some injuries that you also look for to try and determine whether there was anything that would have contributed Mr. Ellis' ability to breathe?
Yeah, so obviously, if in the course of the struggle that obviously happened with Mr. Ellis, if there had been multiple rib fractures or lung contusions or flail chest or other injuries like that, I think that would be important. We didn't see anything like that.
Have you ever looked at any autopsies that did have that?
I did. I looked at several autopsies from, I believe, Dr. Clark. One did have those injuries, but I believe that the cause of death was still ruled to be methamphetamine overdose.
And some of those injuries that you saw in those cases, you felt were injuries that might be that might cause respiratory issues?
I would say that the forces required to cause those were severe. It's not very often that we see 12 rib fractures and flail chest. That takes an enormous amount of force.
And yet, it was still ruled methamphetamine.
On objection.
Sustained. But not on that ground.
When you formulated your opinion in this case, did you ever base that on the fact that Mr. Ellis was in a prone position of the stomach at the time that EMS arrived?
No, my understanding was that he was on his side or back and side.
When you formulated your opinion in this case, did you ever base that on the fact that Mr. Ellis had a PEA arrest?
No,
Why not?
he didn't.
this jury what your opinion of the cause of death of Mr. Ellis is to reasonable degree of
So my opinion is that Mr. Ellis had a toxic and lethal amount of methamphetamine in his system, and that the effects of that with his underlying heart disease caused his death.
And Dr. Stankus, you're being paid for your time here today.
I am.
You've been paid for the time that you work on this case.
Not yet.
You will. And what's your hourly rate?
It's $500 an hour.
Thank you. I don't think
Cross-examination.
Oops, sorry.
Dr. Stankus, good morning.
Good morning.
So, just to follow up on that last line of questioning, you are, as an expert witness, compensated for your work, is that correct?
I am.
No different than other defense witnesses or the state's expert witnesses, correct?
Correct.
And then you also charge an hourly rate as well as a flat rate for your testimony, is that correct?
Correct, if it only goes 4 hours. So I charge a minimum of 4 hours for a day.
Gotcha. Okay. Now, want to just talk about your background for a little bit here. You were a police officer in Colorado, is that correct?
Yes,
Okay. And in fact, you have a family member in law enforcement currently, is that correct?
I do, one.
And you describe yourself as pro-law enforcement in the past, is that correct?
I have not described myself that way.
Okay. During your time as a police officer, were you trained on the LVN home?
object beyond the scope.
Sustained.
Dr. Stankus, you are currently a contract emergency room physician at Madigan, is that correct?
I am.
What does it mean to be a contract physician?
So there are 3 types of physicians out at Madigan. One is active duty. Another would be a Department of Defense employee, and then contractors. So I work for a contract company that supplies, I don't know how many of us are out there now, maybe 10 emergency physicians for the department, in large part because there are so many deployments and other things, it's really hard to staff the department.
Okay, what contract company do you work for?
Oh boy, it changes a lot. I think it's called Eagle Health or something like that. I'd have to look.
Okay, so you're employed by Eagle Health, contracted out to Madigan.
Correct.
Okay. Is this a full-time position or part-time position?
It was full time up until about 2021 when I went down to a .75, and then over the last year I've been probably between .5 and .75.
So 0.5 meaning half-time?
Yes,
Okay, so your employment then is sort of on a half-time to three-quarters time basis?
correct.
Okay. How much of your time is devoted to your work as an expert witness?
It varies greatly. This week it's a lot, but I would say between 10 and 30%.
So 10 and 30% of your work currently is devoted to your expert testimony, is that correct?
Or review of cases, yes.
And are you also involved in business ventures such as media projects?
Yes.
Okay. Why don't you tell us about that?
So I'm involved in, so it's kind of a long story. So a couple of years ago, I was involved in a reality adventure show or survival show. And since then, it's a new company. I haven't had an interest in creating new content for that show and have been working to do that.
How much of your time is devoted to that venture?
Again, that's variable. I would say maybe on the weeks that I'm involved in these adventure things, 100%, but really it's only about 5%. It's not a lot.
You are, is it fair to say that your work as a physician is exclusively in emergency medicine, is that correct?
Yes, sir.
All right. So you are not board certified in cardiology, for example?
Correct.
And you're not a cardiologist?
I'm not.
And you are not a pulmonologist, correct?
I'm not.
You're not a pathologist?
Thankfully, no.
And did you perform any analysis of tissue samples in this case?
I did not.
And you've never examined Mr. Alice's heart in this case, correct?
Correct.
And you've never done a forensic autopsy?
Correct.
You're not a toxicologist, correct?
Correct.
Are you a member of the American Medical Association?
I am not.
And again, you're not an expert in police use of force, is that correct?
No.
Do you have any formal training on positional asphyxia?
Formal training?
Correct.
No.
And you don't have any experience with positional asphyxia, is that correct?
Only from the standpoint of, as an example, a car falls off a jack on a person in a garage. I've seen that. But in terms of what you're talking about with police officers, no.
Because during an interview with our office, you were asked, what is your experience with positional asphyxia? And you said none. Is that correct?
Correct.
Have you ever provided expert testimony on sudden cardiac death?
I have not.
Have you ever provided testimony on cardiac arrhythmias?
I don't believe so.
Have you ever provided expert testimony on respiratory failure?
I don't believe so.
What about hypoxemic conditions? Hypoxic
Oh,
conditions?
not that I'm aware of.
Not that you
No, I don't think so.
never have, right?
I don't believe so.
Have you ever provided expert testimony on the need for physical restraints for patients?
No.
During your review of this case, did you review witness statements involved in this case?
I did.
And you reviewed the officer's statement as well?
I did.
Now, you would agree, Dr. Stankus, that there's no minimum or maximum amount of methamphetamine that medicine can say definitively will cause death, is that correct?
Yes.
And you would agree that not everyone who uses a high dose of methamphetamine dies, is that correct?
Correct.
And you would agree that many people survive even at the level of methamphetamine that Mr. Ellis had on board, is that correct?
I don't know that you can answer that question.
Did you not answer yes when that question was posed to you?
I may have. I don't recall.
Okay. Do you want to review the transcripts?
I don't need to. I think just answering that question, do a lot of people survive with that level of meth? I don't know that you can, that there has been a study asking people to take that amount and see if they die or not. I just don't know that we know what those numbers are. So if I answered differently in the past, I apologize, but that's how I would answer now.
But as far you would agree with me that you actually answered yes when that question was posed to you during your interview with all?
I may have.
Okay.
I mean, I believe you.
Okay, but you're changing your testimony? Is that my understanding now?
It wasn't former they interviewed her for 3 days.
That's a matter of phraseology, I suppose. So I'm not going to get worried about that. But you may answer the question.
So So, sometimes when I'm asked a question, I may think about it differently. And so what I would say is I'm just answering the question as best as I can here in my testimony. So if I'm changing my testimony, would I agree thinking about it maybe a little bit differently right now? I don't know how you could know that. And so that's my testimony.
So you're changing.
Sure. Sure.
You talked a little bit about dealing with people who are intoxicated on meth in the emergency room setting, is that correct?
Yes.
When you examine or treat people in the ER that you believe are intoxicated on meth, you don't actually measure the amount of meth that's in their blood, correct?
Correct.
So you wouldn't know what amount of meth is in a particular patient, is that correct?
Correct.
And you do believe that downward force on Mr. Ellis's torso in this case would have restricted his ability to breathe, is that correct?
So would it have restricted his rib cage to a certain extent? Yes. I don't know that that you can say, so breathing requires oxygenation and ventilation, and in looking at how much force is required to have a clinically significant effect on that is obviously a question that has been raised multiple times that hasn't been answered.
Okay. Do you recall being asked that question during your interview with our office?
I do.
Okay. And you recall indicating that downward force on Mr. Ellis's torso would have restricted his ability to breathe?
Again, would it restrict his, yes, I do. I also think that I may have qualified, okay.
He's going to ask questions at the interview. You should show it there.
I'll allow her to complete her answer, how's that?
What I would say is, I believe I probably would have qualified it with, would it restrict your breathing to some extent? Yes, I gave some examples of other things that could restrict breathing, but that may not have a clinical, may not be clinically significant.
Did you, Dr. Stankus, review the fire department's pre-hospital care report?
I did.
And did you rely on that for your opinions?
I did.
Your report indicated that the paramedics stated Mr. Ellis had adequate respiratory drive. Is that correct?
I think that it, one paramedic said that, I believe that Lieutenant Wilson said that he had shallow respirations that were not adequate. There was definitely some mixed testimony there.
Okay. But the report that you prepared in this case, you indicated that Mr. Ellis had adequate respiratory drive. Is that correct?
I did.
And what does having adequate respiratory drive?
Breathing on his own is what I meant by that.
So Mr. Ellis was breathing when paramedics arrived. Is that correct?
That was my understanding, yes.
And the pre-hospital care report indicated that Mr. Ellis was unconscious. Is that correct?
Yes.
That he was unresponsive. Is that correct?
Yes.
Would being unconscious and unresponsive affect the effectiveness of the BVM?
It's definitely a serious condition. Would it affect the effectiveness? So, no, it should be effective. As, you know, there shouldn't be a lot of resistance to its use.
And in the pre-hospital care report, Lieutenant Wilson indicated Mr. Ellis had minimal respiratory drive. Is that correct?
Yes, that's what he said.
And he indicated that respiratory drive was deteriorating. Is that correct?
Yes.
And he indicated that respiratory drive was not sufficient to maintain life. Would you agree with that?
Yes, and I believe that's why he started using the BVM.
Okay. You have no reasons to disagree with those observations. Is that correct?
I don't.
And the pre-hospital care report prepared by Lieutenant Wilson also indicated that Mr. Wilson, or Mr. Ellis, when he arrived at his side, he was apneic. Is that correct?
I'm sorry, say that one more time.
The pre-hospital care report, Exhibit 24, paramedic Wilson indicated that when he arrived at Mr. Ellis' side, that Mr. Ellis was apneic.
That mischaracterizes the statements of Lieutenant Wilson also.
I don't know, let the jury decide. You want to restate it so that my reporter can get your...
Again, I said this case mischaracterizes Lieutenant Wilson's testimony as well as his report.
Continue, you may answer.
So the way I read this was, may I read from the report? So he says that they arrive at the patient's side, they remove the restraints, they remove the clothing, and they remove the spit hood, and they do a rapid patient assessment. After that, the patient becomes apneic with bradycardia, which despite BVM airway management rapidly deteriorated to cardiac arrest. So I'm looking at that as all of those things happening. So that's how I read it.
Okay, thank you. So, and apneic means he stopped breathing, is that correct?
Yeah, he stopped breathing at some point.
And bradycardia means he had a slow heart rate?
Yes,
So his respiratory drive has stopped, is that correct?
yes,
And after his respiratory drive stopped, then he went into cardiac arrest, is that correct?
yes,
And cardiac arrest means his heart stopped, just in simple terms.
by definition, yes.
Okay. So in simple terms, Mr. Ellis stopped breathing and then his heart stopped, is that correct?
Yes,
The pre-hospital care report also indicated that Mr. Ellis' eyes were fixed and dilated, is that correct?
yes.
Based on the status of Mr. Ellis when paramedic Wilson arrived, that he was not breathing adequately and that his heart was not perfusing adequately and his eyes were fixed and dilated, does that tell you he was hypoxic?
So just focusing on the eyes alone, I would expect his eyes to be very dilated with very sluggish response, given the amount of meth. That would be a normal thing. Whether that is due to the meth or other causes, I don't know, but it could be attributable to meth alone. But he is he's unconscious, and he is he's got the shallow breathing on arrival, is my understanding.
You indicated several times that you took issue with the fact that Mr. Ellis had normal sinus rhythm, is that correct?
Yes.
Nowhere in the pre-hospital care report indicated that he had normal sinus rhythm, did it?
Not that, let me see, what did he say?
And I'll direct your attention to the third full paragraph where it described sinus rhythm deteriorating into bradycardia and systole.
Yes,
So it doesn't indicate that it was normal sinus rhythm, correct?
correct. Yes.
Would you agree that the only way to bring someone out of ventricular fibrillation is with electrical shock?
It is the way that we would have to do that most of the time. I think that there are some case reports of someone coming out of it, but I would expect most people would need to be shocked, yes.
And you agree that the initial EKG strips in this case does not show ventricular fibrillation, is that correct?
I do.
And you would also agree that the initial EKG strips do not show ventricular tachycardia, is that correct?
The initial strip, yes. So when you're, may I just ask for clarification? When you're asking about initial strips, you're just talking about that first one that, okay, perfect. Thank you.
It doesn't show that, correct?
Correct.
And you would agree that prior to being administered epinephrine, there was no evidence of ventricular tachycardia or fibrillation on Mr. L's EKG strips?
Yes, may I respond back to the sinus rhythm? So in atrial flutter, it's not actually considered sinus rhythm. So I would say I disagree with that.
Now, you talked about the corsage. You mentioned that.
So we'll take our recess. Ladies and gentlemen, please be back by 1:15. Please discuss the case among yourselves.